Thanks to CureJM and thanks to everyone for taking the time to participate in this WebEx about understanding second-line treatments and side effects. And I don't have any relevant conflicts of interest, and Dr. Curran and myself organized this such that I'll be talking about oral medications, and Dr. Curran will talk about injection and intravenous medications. So I was going to start with a quick review of things that were discussed in the previous WebEx. Overall, our goal with treatment of juvenile myositis is to treat an overactive immune system. And this is done by targeting different parts of the immune system, which could include an overactive white blood cells, which could be T cells or B cells or other particular immune cells, antibodies, and immune system chemicals. And this approach is also guided by how severe the disease is and what characteristics an individual has. So it, of course, varies person to person. And there are two general ways that we've mentioned before about how this can be done, how to treat an overactive immune system. One is by suppressing the immune system. So that does address the goal of treating an overactive immune system. It reduces the way the immune system can function overall, but that does come with a risk of infection because the immune system is not working well. And then there are some medications that modulate the immune system. So they still help us in our goal of treating the juvenile myositis associated overactive immune system, but don't carry the risk for additional infection or additional risk for infection. And briefly, the medications that we talked about in our previous WebEx for initial treatment or induction include steroids, methotrexate, hydroxychloroquine, intravenous immunoglobulin or IVIG, and we talked briefly about how exercise and sun protection should always be a part of the treatment as well. And briefly, several of the questions related to some of these medications we talked about previously. So with steroids, someone asked about whether or not there's any alternative to daily steroids, because it sort of seems like a Band-Aid and it always seems to come back and higher doses are required. And you may recall from Dr. Curran's excellent talk about this at the last WebEx that we know that steroids are very effective in addressing an overactive immune system. It works quickly, it's very strong. You may remember there's a graphic of a Hulk, or people describe it as like a sledgehammer. It's very effective and very strong at decreasing the immune system, and generally very reliable in being effective in treating the symptoms of juvenile myositis, but it does have a lot of side effects. So that's why we try and use a lot of these other medications to help wean off of the steroids, or ideally be able to get off the steroids completely. But we don't know exactly what's best for each person, and that's why there are a lot of different medications that are being studied and tried. Another medication about the steroids was about the potential for decreasing the side effects of prednisone by combining it with hydrocortisone. I personally have not tried that, and I had talked with several colleagues who have not done that either, but I did find in the literature it was discussed about potential benefits of combining hydrocortisone with dexamethasone in the setting of treating pediatric cancer. Because dexamethasone works a little differently than prednisone, it works on different receptors in addition to being more targeted for the getting to the brain, which is less important in myositis. We wouldn't expect to have the same potential benefit of combining those things together, combining the hydrocortisone, but it hasn't been studied formally, but I'm not sure that it would have the same benefit that's described in the other patients with cancer with dexamethasone. There's a question about hydroxychloroquine. One question was about how long should it be continued even if it hasn't had a clear benefit in the overall disease. So that's certainly a question we have really with any of our medications, how long should we be on them and what's the risk versus benefit. As you may remember from the previous WebEx, hydroxychloroquine is considered an adjunct medication. So it may have some benefit in skin disease, and it also may help someone be able to be on less steroids overall, for example, and it is in the immunomodulatory category. So in some senses, at least, it has less of a severe side effect profile. But there are some people who continue on hydroxychloroquine, or some rheumatologists who would keep their myositis patients on hydroxychloroquine because it may be protective, potentially in decreasing the amount of bad flares in the future, but it's not something that can be the same answer for everyone. So it's something that can be discussed further with your doctor. Also, someone asked about potential alternatives to hydroxychloroquine. Hydroxychloroquine is kind of unique and in its medication category as this adjunct type of medication. It's not usually considered as the first line medication to be the most powerful in addressing the symptoms or the immune system symptoms in myositis. So there actually aren't other alternatives that I can think of that are exactly like that, but there are other medications we use in general, some of which that we discussed before and some more that we'll talk about more today. With IVIG, there was some questions about how to try and avoid side effects. And in the question, there are a lot of comments about things that they already know about. I'll just review them briefly. So I'm not sure that there are new things, but one thing I didn't see as part of the question is just slowing down the overall rate of infusion, which is something a lot of people try. It is balancing what's possible for you and your family, like practically and with insurance. But there are some people who spread the infusion out up to like 24 hours, which might mean, needing to stay in the hospital overnight rather than having a day infusion or a home infusion, or separating the infusion out into 2 separate days. But otherwise, in general, things that are thought to help with the side effects of IVIG are just being very well hydrated prior to the infusion, which might just mean like drinking a lot of water, or sometimes people do an IV fluid extra bolus or extra amount of IV fluids before and or after the IVIG, changing the formulation of the IVIG to have less glucose or IgA, or having less overall kind of thickness to the formulation or osmolality. And these should be things that you can discuss with your rheumatologist, and medications that can be given before the infusion, which are commonly done, like giving acetaminophen or Tylenol, steroids, or diphenhydramine or Benadryl. Okay. So next we'll start on talking about some of the second-line medications, the main topic of today's WebEx. So these are medications that are considered by rheumatologists, or that should be considered when after the initial period of treatment with induction with the treatments that we've already discussed, either the person is not really able to tolerate those medications and or the medication is still active. So these second-line treatments are sometimes considered as an alternative, like switching one out for the other, or sometimes they're considered as add-on therapy with the goal of getting the disease completely inactive or getting to remission. So the first one I'll mention is mycophenolate mofetil, or MMF. That's the generic name for the medication. The brand name is Cellcept. This is an oral medication. It can be in tablet, capsule, or solution form, and it's can be dosed by the body surface area, 600 milligrams per meter squared, and can be divided into 2 times a day or up to 4 times a day. There is another format of this medication called enteric-coated, which has the name Myfortic, and it has a little different dosing. So just a note, if you switch from one format of MMF to this Myfortic type of medication, even though they're both the same underlying medication, the dosing is different. This medication works by decreasing this particular enzyme, IMPDH. It blocks this enzyme, and it blocks certain types of DNA and RNA synthesis. And this is thought to help with addressing the overactive immune system by decreasing the rapid turnover in particular cells in the immune system, particularly T cells. Most common side effects that can be seen with this medication are an upset stomach, nausea and vomiting, and diarrhea. Some of these GI or GI-related symptoms may improve with dividing this dose into smaller doses over the day, so the same total overall dose for the day, but instead of giving it twice a day, dividing into 4 times a day. But as this is one of the more common side effects, this is likely why the enteric format was also developed. So that is something that can be considered if this is a prominent side effect when someone starts CellCept or MMF. Other side effects that can be seen are headache, dizziness, difficulty sleeping, tremor, and rash. But for many of these side effects, they can, if they're able to be tolerated in the short term, they can go away with time. Another side effect that can be seen are low blood cell counts. So this is monitored by taking blood and checking the laboratory tests. It is reassuring that these low blood cell counts are known to resolve when the medication is stopped. And sometimes it is a little bit of a balance based on how low the blood cell counts, which are likely a sign that the medication is working versus what's safe. Looking at that and balancing the dosing of the medication. And then this is in the category of immunosuppressive medication, so it would be associated with a decreased ability to fight infections, similar to some of the medications we discussed at the last WebEx. So as with all of these medications, and you'll see this come for some of the other medications that I mentioned, in order to try and help minimize the risk for this, at least some rheumatologists will recommend not giving vaccines that are live vaccines while someone is on an immunosuppressive medication. As mentioned before, the live vaccines are vaccine formats where a format of the infection, but a less strong version or an attenuated version of the vaccine is given. And in general, with a healthy immune system, they would never cause the infection. But with someone with a suppressed immune system, they have a higher risk of actually developing the true infection. So the most common live vaccines are the MMR vaccine, measles, mumps, and rubella, and the varicella vaccine, which are usually given at 1 year and 4 years of age. Most of the vaccines are killed vaccines where it's just like a piece of the infection, which would never lead to causing the infection, and that's safe to give because even with a suppressed immune system, it wouldn't cause the infection. And just in general, to limit the chance of infection, good hand washing, regular hand washing before eating, in public places, in schools, at public gatherings like at malls or churches is a good idea. And of course, trying to avoid direct contact with individuals that have symptoms of or a known infection. And we do know that the mycophenolate or MMF is a contraindication for pregnancy. It can be dangerous during pregnancy, so this is just something to keep in mind for particularly girls and females of reproductive age to consider alternatives. Next medication we'll discuss is cyclosporine. So this comes in multiple formats. One format is called Neoral, and it's called a microemulsion format, which means it's a form of cyclosporine that was developed to be absorbed more consistently and at a different level than the alternative, which is usually called Sandamine, but it has other names as a generic. And I just point this out because as this arrow points to, because of these different formats, they're not considered equivalent. So even though they're both cyclosporine, if you usually get one format, you shouldn't just switch to the other format based on what's available at the pharmacy, because they will have different absorption and different levels of the drug exposure to the body and may have different effects. So cyclosporine, just highlighted here, also works on immune cells. It follows this pathway and is thought to block a certain communication within this immune cells to interleukin-2, which is one of the cell communication molecules connected to upregulating T cells in the immune system, T cells. So that's how it's thought to help address an overactive immune system in juvenile myositis. There are some side effects that are possible with this medication. It can cause kidney damage. It can cause an elevated blood pressure and electrolyte imbalance. This is monitored by checking laboratory tests both in the blood and in the urine, by monitoring blood pressure And we do know that these side effects can resolve with stopping of medication. And as mentioned, like with mycophenolate, sometimes the dose may need to be modified based on what side effects are seen. Sometimes an additional medication is added on to manage symptoms, like sometimes the blood pressure medication is added to manage elevated blood pressure if it seems like it's otherwise working well, or based on how serious the side effects are, it may require a change in therapy. But for this medication, we do know that there's generally a certain range of drug level that's a goal. So this is a medication where drug levels in the blood are monitored as well to help titrate the best dose for an individual. Other things that can be seen are extra hair growth. Can also be seen that there's extra tissue or like a buildup of tissue or swelling around the gums, headache, numbness, and tingling. When these symptoms, they're just monitored for, and it's also we can try and correlate with a certain drug level in the blood, titrate the level of the medication as well. And this medication, cyclosporine, is also in the category of immunosuppressive. So it does decrease the immune system's ability to fight infection. So it's the same precautions as before. Tacrolimus, or FK506, or Prograf, is another oral medication. And this is the same picture because it gets to the same pathway, but in a different format. So it's this purple icon. It also blocks the signaling of interleukin-2, so it decreases the T cell activation or an immune cell activation. So cyclosporine and tacrolimus, they have a similar downstream effect, but they act in different pathways. But overall, the side effect profile is similar to cyclosporine. That's why it's not listed here. It doesn't have all of the same side effects. It's a little bit less of some of the side effects that were on this side, but overall, the side effects are similar. The next medication is Azathioprine, also called Imuran. This is an oral medication, and it gets activated into a different format called 6-mercaptopurine, or 6-MP, which is also commonly used in inflammatory bowel disease. And this medication, similar to some of the other medications we've heard about, acts to inhibit certain types of DNA synthesis in the immune system, and that's how it's thought to work in juvenile myositis. With this medication, some of the more common side effects are in the gastrointestinal system. There can be oral ulcers, nausea, vomiting, diarrhea, and belly pain. And there also can be liver enzyme elevation, which is something that would just be seen in laboratory studies and not something associated with any symptoms. And we do know that sometimes taking this medication after eating or dividing it into 2 times a day instead of once a day may help with some of these symptoms. And we do know that these symptoms or side effects are generally reversible. Another side effect that can be seen with azathioprine is low blood cell counts. In particular, there are certain genetic variants, and one of the pathway along which azathioprine works, called TPMT, such that if someone has a low activity in this TPMT, it may direct the azathioprine to work more in other pathways and lead to more of these low blood cell counts. So oftentimes people check for what type of genetic variant of TPMT someone has before starting this medication to be on the safe side. Or sometimes it's checked after checking the blood cell counts, because if the blood cell counts are fine, it isn't necessary to check that TPMT. There's some variation between practices, but just something to be aware of, that in addition to just checking the counts, sometimes having this particular genetic variant can contribute to having more of this side effect. And if someone had that side effect and they were having a lot of the white blood cell side of low counts, then likely an alternative medication would be chosen. Azathioprine is also in the category immunosuppressive, so that it results in the immune system overall being less active and less able to fight infections. So this has the same precautions as before: holding live vaccines, good hand washing, and trying to avoid direct contact with individuals with an infection. And I just wanted to mention on this last slide that I have about medications that treatment that's currently being studied, and you may have seen it's been mentioned also in some of the emails from CureJM, is a category of medications called Janus kinase inhibitors, or JAK inhibitors. At least some of the interest in this category of medication is it's known that one of the cell communication markers called interferon is high in juvenile myositis, and it's not necessarily specifically targeted by the other medications that we have in our treatment pathways. But Janus kinase inhibitors, though they don't only target interferon, it is targeted amongst other things. So it has something that's a little bit unique compared to all the other medications that I mentioned. Though we do think probably steroids may address some of the same pathways, because steroids is such a big Hulk and sledgehammer. It addresses so many things in the immune system. But the Janus kinase inhibitors are of interest, and there have been particular cases that have been reported about more in adult myositis. Tofacitinib, for example, this first one listed here, which is approved for adult rheumatoid arthritis, has been studied in a small number of adults with myositis and seems promising for being able to treat weakness and the skin features in dermatomyositis. And I mentioned baricitinib here as well. It's also approved for adult rheumatoid arthritis, but in a small number of patients with juvenile myositis who has still had disease activity after trying several of the medications we've already mentioned. Seems promising for having improvement in juvenile myositis patients. But I think this is a category of medications where we are excited about the potential, but it's something we're studying more. So hopefully we'll hear more about these in the future. So with that, I'll switch over to letting Dr. Curran talk some more.
Okay. So I'm going to just take over from where Dr. Kim left off. I also have no disclosures. I'd like to thank Dr. Ardalan for some slides that I modified, and for some of the presenters at the conference on myositis that Dr. Kim and I were at recently, who gave me some ideas for the talk. So what I'm hoping you can learn from my discussion is possible intravenous second-line medications. Can everyone hear me okay?
Yes.
Okay. What are biologic medications for people who don't understand that concept? How the different medications work, various side effects that I won't go into too much detail, and a little bit about some studies that have been published about various medications. And these are all of the different drugs that I'm going to talk about. So first, I'll just give you some introductory concepts. So for the autoimmune diseases that we take care of in rheumatology, the underlying problem is that white blood cells are overactive and causing inflammation in tissues where they shouldn't. And this is an overview, this slide is an overview of the various cells that are part of the immune system. And the reason that I show you this is because this is where in various cells here are where the drugs that we're going to talk about are targeted. Some of you might know these little abbreviations next to the types of cells. If you are familiar with flow cytometry testing for your child's white blood cells. So I just included those in case those letters are familiar to you. The most important thing to take away from this diagram is that we have two types of white blood cells, those called lymphocytes and those called granulocytes. And the lymphocytes are the main effector cells of the immune system. Anything that's labeled with this red APC, antigen presenting cell, basically means that it's a way for immune system cells to talk to each other. You probably are aware of different types of white blood cells, lymphocytes, called T cells and B cells. And T cells secrete cytokines, which are inflammatory chemicals, and we're going to be talking about those too. So as we go through the medications, I'll be showing you kind of where in the diagram different medications are working. The other slide that we'll keep coming back to is this timeline of how different medications, when different medications were developed for use in rheumatologic or autoimmune diseases. Way back starting in the 1930s, we had medications like ibuprofen, the non-steroidal anti-inflammatory drugs. And in the 50s, steroids were began being made and used in rheumatic disease. And then you can see over the course of time how rapidly some of our newer medications have been developed. So an important term to know is DMARD. We use this a lot in rheumatology. This stands for disease-modifying anti-rheumatic drug. Basically, these are immunosuppressive or immunomodulatory medications that are essentially all of the medicines we've been talking about in these webinars. There are two types of DMARDs. There are ones that are synthetic, that are actually made in a chemistry lab, that they're small chemical molecules. So Celcept, which is mycophenolate mofetil that Dr. Kim talked about, is a synthetic DMARD, and these can be taken orally. Of the synthetic DMARDs, there are some that are conventional that have a broad focus on all of those immune cells that I showed you, and others that are targeted towards specific pathways. There are also biologic DMARDs that are made using antibodies, and antibodies are large proteins that if you took them by mouth, your stomach acid would just break them apart. So biologic medications by definition must be given intravenously or by an injection underneath the skin. There are some experimental non-drug treatments that we're not going to discuss today. I just wanted to mention that there have been reports of utilizing plasma from healthy donors, which is the liquid portion of blood, or exchanging plasma, like removing the liquid portion of blood using a machine and replacing it with other types of serum blood products, including IVIG. And then there are also reports of stem cell transplant in patients with myositis. And just to bring you back to this diagram, the stem cell is how white blood cells are made. It's basically the parent cell that they all come from. So in stem cell transplants, a patient's white blood cells are just wiped out completely by radiation and other medications, and then new stem cells are infused. And the idea is that with healthier white blood cells, they will not be reactive against your own body. But we won't go any further into that. In just general discussion about side effects of the medications I'm going to talk about, they are all immunosuppressive medications. So it goes without saying that the risk of infections is increased when patients take any type of biologic drug, including the possibility of reactivating any viruses that a patient has been exposed to previously, like varicella, chickenpox virus can reactivate and cause zoster or shingles. Any medication can cause allergies and symptoms like that, or hives or anaphylaxis, where it can be a serious allergic reaction causing trouble breathing. And allergies are a reason to stop medication. But biologic medications can also cause something called an infusion reaction, which has some similar features to an allergy, but it doesn't cause true anaphylaxis. So an infusion reaction might be a reason to slow down an infusion, but not necessarily a reason to stop giving the drug entirely. And of note, all of the medications that I'm going to talk about are not FDA approved for myositis, but we do use them in other rheumatic diseases. So cyclophosphamide or Cytoxan is an older medication that was discovered in the 1950s. And cyclophosphamide essentially kills off white blood cells. It causes cross-linking of DNA, which makes cells die, and it prevents them from dividing. And it targets various types of white blood cells, mainly the cells that are affected by Cytoxan or cyclophosphamide are lymphocytes and neutrophils. So all of the downstream cells essentially die off. For Cytoxan, we give this medication as a monthly infusion, usually 6 to 7 times, but there are protocols where it can be given every 2 weeks. And essentially within the first 2 weeks, the medication works to kill off white blood cells, and white blood cell counts go down within the first 2 weeks. In the second 2 weeks, the bone marrow is repopulating with healthier white blood cells, so the cell counts go back up. This is a very strong immunosuppressant, and we use this mainly in the most severe cases of myositis, where patients have cardiac involvement, or they have severe lung disease or weakness to the point where they're not able to breathe due to diaphragmatic muscle weakness, or patients with very severe and rapidly progressive weakness. Cytoxan is a medication that can reduce fertility, especially if there's a lot of exposure to the drug. This is generally a risk in girls only if they've already started menstruating. And in boys who have reached puberty, it's possible for them to donate sperm before getting the medication, just in case there is a problem with sperm production down the road. The concerns for Cytoxan is that because it so fundamentally changes the immune system, it can cause potential malignancies or cancers in the future, including bladder cancer. The next medication we'll talk about is Rituximab, which was developed in the early 2000s. So Rituximab is a medication that targets B cells. So those are over here on this side. B cells are a type of lymphocyte, and B cells can differentiate or grow into 2 types of cells, one called a plasma cell that makes antibodies, and another called a memory cell. And B cells work with T cells to help our immune system fight against infections. In dermatomyositis, part of the problem is that our immune systems can make antibodies that work against the muscles and work against the skin. You may have seen this diagram before for some of the different types of myositis antibodies that are known to be produced. And because Rituximab kills off B cells, we produce fewer of these antibodies. Rituximab is used to treat other rheumatic diseases like lupus and vasculitis. It is thought to be helpful in myositis because B cells are found in affected muscle tissue, and those B cells again produce antibodies that can damage muscle and skin. And B cells talk with T cells, and T cells are also known to be involved in myositis, causing autoimmunity. So the idea is that if we get rid of B cells, they may not be talking to T cells, and that might reduce autoimmunity in general. There were early hints that Rituximab could be helpful in myositis through case reports of patients who got the medication and improved. And one case series was featured 13 adult myositis patients who received this medication and had improvements in all of these different areas of their disease. And so a formal research study called the RIM study was done that was the largest clinical trial ever in myositis. And they looked at patients with refractory or non-responsive or poorly responsive to other medications, myositis, both adults and pediatrics. There were 2 groups of patients in the study. So there was a group of patients who started Rituximab right at the beginning of the study. And then there were a group of patients who were whose disease activity was monitored for 8 weeks without Rituximab, and then they started Rituximab later. And the way this study looked to decide to see if patients got better is they made a definition of improvement that included things like improvement of patient's strength. After 44 weeks of receiving Rituximab, 83% of the patients in the study met the definition of improvement, which was really impressive given that these patients had previously received lots of steroids and other immunosuppressants and had not improved significantly, but they did after receiving Rituximab. However, this is the RIM study is thought to be a negative study, meaning that they did not meet the endpoints of the study. And the reason is because both groups improved, and there wasn't a difference between the patients who got the medications first versus the patients who got the medicines later. And the idea was that if the medication works, you would think that the patients who got the medication first would improve first. The problem is that rituximab is a medication that takes quite some time to work, and so that 8-week difference may not have been enough time to really know if the patients who got the medication early responded earlier than the patients who got the medication late, if that makes sense. So even though the RIM study was negative, there were a lot of good things that came out of the study, and we actually felt that rituximab did help the patients who received it. So we feel as rheumatologists that rituximab is a helpful medication in myositis. It did allow patients to reduce their dose of steroids, and many patients in the study improved with the medication. Additionally, patients who got rituximab a second time after flare also improved. And these are the reasons that the study was thought to be a negative result, like I explained before. There was a trend towards a difference in the JDM patients compared to the adult patients. We actually thought that JM patients responded better to rituximab than the adult patients, but there weren't enough patients to make firm conclusions. There were also some follow-up studies that looked at the RIM data and analyzed it in a second way or other ways. They found that patients who had myositis antibodies improved more quickly than patients who did not have identifiable myositis antibodies when they received rituximab. Like I said, it looked like juvenile myositis patients responded more quickly than adult patients, but this could be confounded by the fact that children with myositis might have less damage and may improve more than adult myositis patients in general. We also found that patients with lower levels of muscle damage seemed to improve better than patients who had more muscle damage when they got rituximab. So the questions that were raised after the RIM study is wondering whether rituximab is a reasonable initial therapy. Right now, it's not an initial medication that we give for juvenile or adult myositis. It comes as a later medication when patients don't respond well. We still are trying to understand which patients might benefit the most from rituximab, if kids are more likely to respond than adults, whether patients should be retreated with rituximab after a certain number of months, because B cells will start to come back after about 3 to 6 months of receiving rituximab. So then we wonder if we need to retreat. And then we also are wondering if rituximab may have a role for helping skin rashes and lung disease, not just muscle disease. Side effects of rituximab include immunosuppression, and there's a warning about a particular virus that can cause an inflammatory brain disease that is exceedingly rare. Because rituximab kills off B cells, it can decrease all antibodies that are produced in general, which can make a patient more susceptible to infection. And rituximab is pretty notorious for causing an infusion reaction in about 30% of patients who get it the first time. Generally, this is not a true allergy, but just a reaction to the infusion that will improve if the infusion is stopped and slowed down. So that was a quick talk on rituximab. We'll move to Abatacept or Orencia that was also made in the early 2000s. So the way that Orencia works is that it prevents different types of white blood cells from talking to each other. So those APC antigen presenting cells are not able to talk to different types of T cells, for example. And that basically means that the white blood cells are unable to become activated and therefore unable to attack muscles and blood vessels and skin. It particularly blocks a certain signal within the cells called CTLA4, and CTLA4 has been found in affected muscles. We use Abatacept or Orencia to treat juvenile arthritis. We use it in lupus patients who have arthritis. And it's a good medication if liver or kidney disease prevents use of other medications like methotrexate. So there are case studies showing improvement of myositis with the use of Abatacept. And there are larger now groups of patients who have been treated with this medication that have shown that it is shown to be effective. And there's a clinical trial underway at the National Institutes of Health that is still looking for patients to enroll. But it is also possible for medications like biologics like Orencia to be used in any center. It's just a matter of whether the patient's insurance will approve it. Side effects of Orencia is that one effect is that it takes a long time to actually work, so it's not a medication that we expect to see results from quickly, and that can be difficult waiting essentially for the medication to work. It's generally a well-tolerated medication, but it does suppress the immune system. We'll move now to TNF inhibitor medications. So there are all different types of TNF inhibitors that were developed in the early 2000s. And these are really popular medications that are on TV all the time now because they have many uses, which I'll talk about in a second. But the way that TNF inhibitors work is that they block cytokine called tumor necrosis factor. There are many different cytokines that are made by T cells, and the meds that we're going to talk about moving forward are all blockers of cytokines. So TNF is a cytokine that makes white blood cells turn on and produce inflammation. So when you block it, it should decrease inflammation. But interestingly, TNF, when you block it, it causes an increase in another cytokine called interferon. And interferon is already too high in many patients with myositis. So there have been reports that using TNF inhibitors can actually worsen the disease in myositis. But it's conflicting because there are some patients who certainly benefit from TNF inhibitors. So the data is really mixed on using TNF inhibitors. I have used TNF inhibitors in some patients with juvenile myositis who also have psoriasis. TNF inhibitors are FDA approved for the treatment of psoriasis. They're also FDA approved for juvenile arthritis, and they're also used for inflammatory bowel disease. So for some patients who have psoriasis in addition to their myositis, this may be a good medication to be helpful. There right now are 4 different TNF inhibitors that are the most popular ones. The only one that is IV is called Remicade. The other ones are subcutaneous injections that can be done at home. Besides causing immunosuppression, interestingly, some patients who don't have psoriasis to begin with, when they're treated with a TNF inhibitor, can develop psoriasis. So this is kind of a confusing piece of information about this medication. It can also cause autoimmune side effects, including a lupus-like syndrome and inflammation in nervous tissue, although these are very rare side effects. There is a black box warning on TNF inhibitors when you read the labeling of the medication that says that patients who have taken this medication have been found to develop cancer, but it's really not a clear cause and effect. So in rheumatology, we tend to take this warning with a grain of salt, and your rheumatologist could explain why in more detail. It's also important to know that TNF inhibitors can reduce blood cell counts, white blood cells, red blood cells, so we monitor things like that when we have patients on TNF inhibitors. Okay, so moving on, other medication that blocks a cytokine is called Tocilizumab, which blocks an IL-6 cytokine. And this is, again, just showing that it blocks a cytokine down here that's produced by T cells. So IL-6 is also a pro-inflammatory cytokine. So when you block it, it helps to decrease inflammation. And studies have shown that IL-6 is elevated in affected muscle in some patients with myositis. So that's the reason why we think that it may be effective. We already use this medication in juvenile arthritis. We are using it off-label in things like scleroderma and vasculitis. but it is FDA approved for certain types of juvenile arthritis. There are case reports of using Tocilizumab in patients with myositis that have shown it to be effective in certain patients, and there's a clinical trial underway in adults. Side effects, again, are immunosuppression, and that it can increase liver enzymes. It can essentially cause stress to the liver. It can also reduce blood cell counts and can increase lipids and cholesterol, which is something that we watch closely in myositis patients to begin with. So it is something that we would watch even more closely in patients receiving Tocilizumab for juvenile myositis. Moving on to our next cytokine blocking medication called Anakinra. So Anakinra blocks something called IL-1. Anakinra is a daily injection. There's also another IL-1 blocker called Cannabinoids that is a monthly injection. So IL-1, again, is an inflammatory cytokine, and we've found IL-1 to be elevated in affected muscle and the walls of blood vessels in patients with myositis. IL-1 can also cause problems with regeneration of healthy muscle tissue. So the thought would be that blocking IL-1 might help patients to regenerate healthy muscle in a more timely and effective manner. We use Anakinra in patients with various inflammatory diseases, including rheumatoid arthritis. There are case reports of using Anakinra in patients with juvenile myositis, including one in a patient who had very inflammatory myositis associated with MDA5 antibodies. Side effects of Anakinra is that it can also increase liver enzymes and cause liver damage, just like we talked about with the Tocilizumab or the IL-6 blocker, and again, immunosuppression. Moving now quickly to some treatments that are even newer medications. So Sifalumab is a medication that blocks a cytokine called interferon. And interferon, again, is made by activated white blood cells. And interferon is thought to be one of the main drivers of inflammation in myositis. So many presentations at our recent global conference on myositis talked about interferon and ways to block interferon to help patients who have myositis. There are different types of interferon. Sifalumab in particular inhibits interferon alpha, which is a type 1 interferon, and that's the interferon that we feel is the most implicated in causing myositis. So when Sifalumab was given to myositis patients, it's been found that T cell associated proteins that make inflammation go down, which is the reason that we feel that this medication is effective. And clinical trials are underway in medications that block interferon. Very briefly, I thought I would just touch on calcinosis treatments. There are a couple of IV medications that are thought to possibly be helpful for patients who have calcinosis in their skin. One is called sodium thiosulfate. That's a medication that is given IV, and there is currently a study at the National Institutes of Health looking at sodium thiosulfate. Bisphosphonates are medications that were developed for people who have loss of bone densities, so bones that are too weak. So I joke that it's the medication that we give to little old ladies to help make their bones stronger, but it actually does have some effects on reducing calcium deposits in the skin as well. And then we got a question from a family about CBD oil. So I thought that I'd talk briefly about cannabinoids. Living in Colorado, where medical marijuana is legal and recreational marijuana is also legal, there are a lot of stores that sell CBD oil. So CBD cannabidiol comes from the marijuana plant, but it doesn't have psychoactive properties. And I do have some families who are giving CBD oil to their children and say that their children with various rheumatic diseases seem to be better in terms of inflammation or pain. but it's really hard for me to know if these effects can be truly attributed to the CBD or the other treatments that they're getting. As far as I know, there aren't any clinical trials or studies that are looking at CBD oil in particular, but there is a medication called Linabacem, which is a cannabinoid type medication that works on similar receptors as CBD or THC. And there have been some studies looking at this drug in patients with adult myositis who have skin predominant disease or very bad skin rashes that have shown some initial success. This is the name of the drug company that has created this medication. I'm not endorsing it by any means, but that's a place where you could find information about that if you're interested. And again, as far as I know, there aren't any studies in kids. And then I just thought briefly I would touch on some of the questions that that were asked. One person asked to know a little bit more about remission rates in patients with myositis. So what we know is about a third of patients who have juvenile myositis have what we call a monocyclic course of disease, meaning that they get sick once, they're treated, they get better. As medications are taken away, they stay better. And as medications are completely removed, they go into a permanent remission. So we call that monocyclic disease. About 2/3 of patients have some sort of polycyclic disease, meaning that either they have trouble going into remission with any type of treatment, or they do go into remission, and as medications are removed, the inflammation returns. So what's really tough about counseling families about remission is that it's really hard to know what bucket your child is going to fall into. And we know that there are some patients who have higher risks of not going into remission, so patients who have much more severe disease or patients who have certain types of autoantibodies. The other thing to think about in terms of remission is how much damage the disease has actually done to blood vessels, to skin, or muscles. So patients can go into remission in terms of no more active inflammation, but they can have damage to various tissues that won't get better. And some patients do have problems with poor muscle function because the muscle tissue has been damaged. So that's a separate concept from remission. Another family asked about trauma and like post-traumatic stress disorder after treatment, such as infusions. Some kids are certainly traumatized by having to get IV access or get poked for blood draws. They're traumatized by coming to the doctor. I think I would think about this similar to kids with any other type of chronic illness, not even necessarily autoimmune disease. And certainly various types of medical treatment can cause stress in children. And it's something that doctors should address on an individual basis, and understanding what kind of stress a child is under and what kind of coping skills the child and family has and how those coping skills can be enhanced. And that's something that pediatric rheumatologists should be able to help with, and also refer to social workers or other counselors to help support a family and a patient in dealing with the stresses of disease. Another question was impact of myositis on ability to get pregnant and deliver a healthy baby. There are some recent studies looking at patients with myositis and their pregnancy outcomes that are generally quite favorable. I think two things to think about would be damage to fertility from medications. Basically, the ones that we worry about would be cyclophosphamide or Cytoxan, causing trouble with fertility. That's essentially the only medication that can cause fertility problems. We also tell patients not to get pregnant while they're taking certain medications like methotrexate or mycophenolate, which is Cellcept, because those medications can affect the development of a fetus. But if the patient is off those medications by the time they try to get pregnant, that should not be a problem. There are some patients with autoimmune conditions have trouble with fertility because they have antibodies that work against a pregnancy from taking root in the uterus, for example. So it might be worth before getting pregnant if certain antibodies are tested. But in general, I guess the one other way that myositis could potentially affect a delivery would be if a woman had significant muscle weakness from myositis. In the study that I looked at, there were only a few flares of myositis during pregnancy. Our general counseling is when a patient is thinking about having a pregnancy, we try to get the disease into as much remission as possible, and then certainly be off any medications that would cause problems with pregnancy. We also got some questions about dietary restrictions, such as going gluten-free to reduce inflammation, or supplements to take that can reduce inflammation, and some question about testing for food allergies. And this is a pretty complicated topic that we could do another webinar on if people have interest. But essentially, what I tell families is that restricting gluten is not necessary unless a patient has confirmed celiac disease. So I certainly test all of my patients with juvenile myositis for the antibodies related to celiac disease. And if they're positive, we have them see a gastroenterologist. In patients who don't have the celiac antibodies, there isn't conclusive proof that restricting gluten will reduce disease activity by reducing inflammation. But it is something that some families choose to do. And as long as patients are getting the appropriate nutrition, if that's a decision that a family wants to make, I generally support it, although I haven't seen any really impressive improvements in a patient's myositis by going gluten-free in patients who don't have celiac disease. I think that's all I'll say, because I know that we are kind of late on time here, and I will give it back to Claire. And thank you so much, everyone, for listening.